Good afternoon, everyone. My name is Michael Lewis. I am the Vice President of Policy here at the American Association of People with Disabilities. Thank you to all who have joined us today for a webinar about the new Medicaid work requirements. Before we get started, I wanted to go over a few housekeeping announcements. Um, there is ASL interpretation and code available if you want to be able to view the captions. If you scroll your cursor over to the bottom of your Zoom screen, there will be a toolbar that pops up on the bottom, and you'll see a little logo that said CC, like closed captions. If you click on that, the captions will start for you. We ask that you avoid using the chat feature during the webinar unless that is the easiest way for you to communicate. Um, if you go back down to the toolbar, you'll see another logo with a speech bubble and a question mark inside of it, and underneath it, it will say Q and A. You can click on that box and type whatever questions you may have for a panelist into that box, and we will get through as many of those as possible at the end. Um, Lastly, this webinar is being recorded and it will be posted with the transcript and captions um, on our AAPD website at a later date, probably within the next week. It does take a little time to upload that, but that will be available. So without further ado, I wanted to go ahead and introduce, well, first of all, as you all know, or may not know, uh, back this summer on July 4th, Congress passed H.R. 1, also known as the One Big Beautiful Bill Act. This bill cut nearly $1 trillion for Medicaid and threatened the health coverage of 70 million Americans. It will cause a major crisis in our healthcare system, which already faces a lot of difficulties supporting people with disabilities and which has been under increased strain since the COVID-19 pandemic began in 2020. Now that we are in 2026, the changes from this bill will start to take effect, and the disability community, all of us, need to get prepared for the upcoming changes to Medicaid. So let me go ahead and introduce our speaker. First, we have Rachel Patterson, who is a disability and health policy expert that worked for her own shop, Patterson and Me. Formerly, Rachel was the director of disability policy for the Domestic Policy Council in the Biden administration. Next, we have David Macklet, who was a senior policy analyst at the National Health Law Program. And finally, last but not least, Adela Flores Brennan, who was the Colorado Medicaid director. So let's jump right in. The first question is for you, David. Let's set out the lay of the land. Now that HR1 has passed and we're into 2026, can you give us a brief overview of how Medicaid has been affected so far and what the most significant changes are, both that have already started to happen and that are coming down the pike?
Sure. Thank you, Michael, and thank you everyone for tuning in today. Um, I'm going to start by just saying, as Michael already mentioned, the One Big Beautiful Bill Act, or what I'll call OBA, has a key feature, and that is that it represents a huge shift of federal resources and federal dollars from the poorest residents in the United States to the wealthiest. Um, there are major cuts to important benefits programs like Medicaid and SNAP, which is an acronym for food assistance, and huge tax cuts that benefit people who are at the higher end of the income scale. And there's some that's the important thing to keep in the back of your mind of all of this. Now, Medicaid is one of the hardest hit benefit programs. Um, Michael mentioned the amount of cuts, nearly $1 trillion over 10 years, and it's projected to leave 7.5 million more people without health insurance at the end of 10 years. The changes in the rule are going to make it harder for individuals to get Medicaid coverage, to stay on Medicaid coverage, and the bill also makes it harder for states to pay for their share of Medicaid program costs. And down the road, it will also increase out-of-pocket costs for some Medicaid and Marketplace enrollees. Marketplace is Obamacare, that's ACA plans, and there's a lot of restrictions there that we aren't really focusing on now. But to take a step back, Medicaid is a partnership between states and the federal government. The state pays a share and the federal government pays a share. States have mandatory and optional services that they have to cover if they're in their Medicaid programs. So, for example, nursing facility services are mandatory. Every state has to cover them. But most home and community-based services that people with disabilities rely on are optional. There are also mandatory and optional eligibility groups. So states have to cover pregnant people, they have to cover disabled people on SSI, and there's other mandatory groups. But there are ones that are optional. And for example, many people with disabilities rely on services provided through 1915C waivers. These are optional. Nearly all states have them, but they're allowed to cut back if they need to. And facing the level of cuts to Medicaid in OBA, we're already seeing states propose cuts to their HCBS programs or to their providers. More specifically, you may have heard already about some of the key mechanisms for these Medicaid cuts. The most prominent is the work requirement for adults who are enrolled through the Medicaid expansion. That is a catch-all Medicaid category for any adult 19 to 64 with an income under 138% of FPL, which is about $22,000 for an individual. And we're going to go into more detail on work requirements later. There's also more frequent eligibility checks and harsher verification requirements that are going to make it harder to enroll and stay enrolled. Those include shifts, for example, to the adult expansion that will require the renewal timeline to change from 12 months, where it is right now, down to 6 months. And every time you have to go through a renewal process, there's more chance for error, there's more chance there's a document missed, and that makes it harder to stay enrolled. The OBA also halted regulations that were meant to streamline eligibility for some people through common disability pathways, and also for people who are dually eligible, who get help from Medicaid to pay for their Medicare cost sharing and out-of-pocket expenses. Third, the bill restricts eligibility for immigrants who are legally in the United States. That includes refugees and asylees who could get Medicaid coverage. And fourth, it restricts as I said, how states can raise their part of Medicaid costs. This is particularly for states that have the adult Medicaid expansion, which are particularly hard hit by these restrictions. And that doesn't mean that a state is going to necessarily it has to cut its program, but it's taking these sort of financing tools out of state toolboxes. And we might hear more about that from Colorado. Like I said, down the road, there's higher cost sharing for some adults in Medicaid expansion. I'm not totally worried about that yet. I think the scope of that is up for debate. There's a new HCBS waiver option, which would allow individuals with slightly lower levels of need to come into the Medicaid program, but that's an optional requirement, and a budget-strapped state may not want to take it on. And finally, there's provisions that would defund certain sexual and reproductive health providers from receiving Medicaid and restrict access to people's to reproductive services.
Thank you very much for that, David. The next question, we have follow-up to that. Rachel, can you go into more detail about the work requirements? What do they mean, and who do they apply to? There's a lot of confusion and apprehension about that, and rightly so.
Yep, absolutely. So before I talk about the work requirement, I kind of want to say a couple of things. And one is how strongly AAPD, the National Health Law Program, and many of the organizations I work with opposed this. So I want folks to know we're going to describe things that are really, really hard and might sound a little scary. And we worked really, really hard to stop them, and we're continuing to work hard to stop them. But my goal here today is to give you the facts so that you have the correct information about what is going on. So if you hear in my tone a sort of straightforward approach, that's why. I want to make sure you have factual information. So when we talk about these work requirements, really they're a reporting requirement. If you have Medicaid, not everybody, which we'll get into, but a lot of folks are going to have to report to their state that they are working, they're in school, they're in training, or maybe they're doing some kind of volunteering at least 80 hours a week. They have to do that in order to keep their Medicaid coverage. This is going to start January 1st of next year, 2027. But your state might start reaching out to you in the fall with information about this. Some states are asking to go earlier, states like Nebraska. So your state might reach out to you really soon, right away. Yes, 80 hours a month. Sorry, did I say a week? 80 hours a month. 80 hours a week would be quite punishing. 80 hours a month of work, school, training, or volunteering. So let's talk about what states this applies to. Dave talked about the Medicaid expansion. That expansion is an option for states to cover adults generally who maybe don't fit through one of other very specific pathways. Most states have done this. They've taken up this expansion. It makes your Medicaid program a lot simpler. It covers a lot more people who really need the coverage. The states that haven't taken up the expansion don't have to do this work requirement. So it means if you live in one of these states, this is not going to apply to you. So that's why I early on wanted to name what those states are, which right now are Alabama, Florida, Kansas, Mississippi, South Carolina, Tennessee, Texas, and Wyoming. And we're going to go over those dates again. So just keep that in mind that this isn't going to apply to absolutely everybody. So let's also talk about who's supposed to be exempt. In addition to folks who live in those states that I just mentioned, when Congress wrote this law, they wrote out a number of people who this requirement shouldn't apply to. In general, people with disabilities are supposed to be exempt. Some of those exemptions are really straightforward. Others are a little more complicated. The more straightforward ones are if you receive supplemental security income or SSI, or if you get services from a home and community-based services waiver. In general, you shouldn't have to meet these reporting requirements to show your work or your education or your training. Congress also said people with disabilities generally should be exempt. But what does that mean? We don't know yet. We have got some information from the federal government. A lot of that's going to be up to the states. That's something that is still being considered, but I think it's really important that we hold on to that people with disabilities are supposed to be exempt from these reporting requirements. And we are going to be pushing really hard for those exemptions to be as broad as possible and for the states to capture people with disabilities who shouldn't have to report. That doesn't mean you're not working. Nowhere does it say your disability has to prevent you from working. What we are saying is it should prevent you from having to fill out all of this extra paperwork just to keep Medicaid. I want to cover a few more exemptions. These include veterans with a total disability rating from the VA. I use sort of air quotes because total is how the Veterans Administration calls it. It's total disability rating. American Indians and Alaska Natives, or people generally who get coverage from or get services from the Indian Health Service, people who are on Medicare, people with substance use disorders or are in treatment. You do not need to be in treatment to get a substance use disorder exemption. And finally, people who are caregivers of children under age 14 or of a person of any age with a disability. So there's a number of exemption categories. Like I mentioned, Congress wrote a lot of exemptions into this law, but the real issue is going to be how do states implement it and making sure that the right people are captured.
Thank you, Rachel. A follow-up question to that. What um guidance did we get over the last several months regarding the work requirements? And you touched on this a little bit in terms of who was supposed to be exempt, but also if you could go into a little bit about who was at risk of being wrongly denied an exemption or included in the group of people that are expected to meet these requirements.
Absolutely. There's two ways. One is I think we're worried about any person on Medicaid being accidentally losing coverage when the law isn't even supposed to apply to them. We are worried about that because this is going to be incredibly difficult for states to implement. There's going to be problems with paperwork, with data, and we're really, really worried about that. The other thing we're worried about is the people with disabilities for whom they are in that expansion category, like we called it, and they should be exempt, but might fall through the cracks because their state defines disability too narrowly, or because the paperwork is confusing, which it is confusing, or because a piece of paper comes in the mail and you don't quite understand it. Something I said in presentations when we were debating this law is like, all right, I want everybody in the audience to think, do you always pick up all of your mail and open it all right away and then fill everything out exactly perfectly the first time you get it? Probably not. Most of us don't. And so, but a lot of what this law expects is a perfection when it comes to filling out paperwork and proving certain information. And that's something that we're really worried about. I think you also asked about what more information we can expect over the next couple of months. The federal government is supposed to put out more formal information by this summer, by June, which should have more detailed information. A lot of the states, however, they need to be putting this stuff together right now. So I know that puts them in a really, really tough position. While they wait for more detailed information, they're also trying to build these systems.
Great. Thank you so much for that, Rachel. Now we're going to go to Adela Flores Brennan, who was the director of Colorado's Medicaid program. And Adela, do the requirements change based on what state you live in, whether you live in a state that has expanded the Medicaid program under the Affordable Care Act or not? And secondly to that, how is Colorado planning to enforce the exemptions that Rachel just mentioned?
Yeah, thank you. And thanks for having me again. This is the second time I get to speak to AAPD. So I am coming to you from Colorado. Colorado is a Medicaid expansion state. So when the Affordable Care Act passed, we did expand Medicaid and take up most or all of the options for expanding healthcare in Colorado. So we're worried about all of these provisions. And because of that, we have created a North Star that we're using to help guide us through our decision making. And that is to mitigate any coverage losses. We're just coming off of a major disruption in Medicaid from, if you'll remember, way back, which isn't that far back, to the public health emergency unwind when we lost coverage for a lot of people. And here we are trying to build some requirements in, but also trying that are, I think, designed to make people lose coverage, but also to try and we're going to try to do what we can to prevent that coverage loss. So in terms of how things change based on the state you live in, there's a couple of things, and Rachel had that great list of all the states that are not required to do work requirements. There's a few other ways that this is impacting states differently, and a lot of them are financial. So Colorado had an almost immediate impact to our state budget of about $1 billion because of the way our tax code is attached to the federal tax code. And so we ended up going into a special session late last summer to start another round of budget cuts. A lot of budget cuts do fall to Medicaid. In Colorado, Medicaid is over 30% of the state budget. And so there's been a lot of pressure on Medicaid to find cost containment and reductions. Another way that states are going to be hit by the HR1 is through financing provisions that a lot of states, most states use. And those are through provider taxes or provider fees. And those don't start hitting states, or it won't start hitting Colorado until about 2027 or 28, but it'll have a huge impact on our budget. And we have 425,000 people who are funded through those provider fees. And those include people with disabilities who are on our buy-in programs. And so that is a huge loss of revenue that is really going to be impactful. Colorado is a state that is an expansion state, and so we do have to implement work requirements. And the exemptions or exclusions that Rachel talked about, we are going to do our best to use the eligibility data that is already available to us to identify who should be excluded based on disability or based on other characteristics like having a child under the age of 14 or being a caretaker there are a lot of ways that we should be able to use our data to identify who the work requirements do not apply to. There um, is going to be also a medical frailty exemption. And as was noted before, it's going to probably be operationalized differently in various states. And this one is something that we're still working to figure out how we're going to um, identify people who should be exempt based on medical frailty. We are looking at a very large list of diagnosis codes that we may be able to import into our system and then use that to filter people based on various types of disabilities or chronic conditions or acute conditions that may prevent them from working. Beyond that, if we don't have any data on somebody, people may need to identify themselves as having a medical condition that would prevent them from working. And then we would have to confirm that in some way. One of the big, well, we don't have formal guidance yet. One thing that CMS has been very clear about is they want everything to be documented and auditable. So we have to me, that says a lot more paperwork and a lot more opportunity for them to look at how we're doing our work and taking care of all of the business. We are really pushing as states, well, some of us, to have self-attestation as an available option and to maximize the flexibility that we have for things like self-attestation. In terms of how we will make sure that people receive an exemption, again, we'll be really leveraging as much as possible our current application and case information so that hopefully we can get through about 60% of the population or more just looking at the data that we already have access to. And then we'll provide additional guidance to our members and stakeholders and county workers. In Colorado, we have a county-based eligibility system. So all 64 of our counties can have face-to-face interactions or phone interactions with folks to help them navigate the process.
But thank you for that. You mentioned the possibility of self-attestation, and that is certainly something that all of us have been involved in conversations with CMS about. Can you give any insight as to what people with disabilities may need to do to prove the eligibility if, for instance, they are not automatically granted an exemption based on existing data from Medicaid or SSI or what have you?
Right. If we are not able to confirm that a person with a disability is exempt because they're on SSI or already in one of our HCBS programs or in one of our buy-in programs in Colorado, then we would need to look at that code list that I was talking about of people who are medically frail or diagnoses that define medical frailty, and then we may be able to exclude people based on that. Then, if we're not, and somebody still says, hey, I have something that is preventing me from being able to work, a chronic condition, a disability that has not been recorded in your system, then we may need something to document that, a doctor's note or something that is going to help us prove to the feds, the federal government and CMS, that we are granting a medical frailty exemption for good cause. So that is still those are still things that we need to identify and define a lot better as we move toward implementation. And we just are in a space right now where there's kind of a well, we're still building this plane while we're flying it. So
Well, thank you. And just to reiterate, it sounds like you're saying if you've already received SSI or you're in Medicaid buy-in or you're in HCBS waiver program, you should not have to reprove your disability. Is that correct?
that's correct. You should not have to. And I think, as Rachel alluded to earlier, I think anytime you're making these big changes in a Medicaid eligibility system, there is always the possibility that something is going to go wrong. And that a lot
Yeah,
of times has to do with the fact that people exist in family units and in households.
yeah.
And we're going to have to look at people on an individual level. So you should not have to, but it's important to remain vigilant and just pay attention.
Great. David and Rachel, this next question here for you. Can you go into more detail about the redetermination part of these changes? Um, and any significant changes that disabled people need to be aware of due to HR1 that we haven't already covered?
Yeah, I can start on this. I do want to say one thing, just in addition to it's sort of like a warning. It's true that people who are not eligible through the Medicaid expansion um, will not be subject to work requirements. It's also really important that people realize that adult Medicaid expansion includes millions of people who have disabilities or serious or complex medical conditions. So, and in the past, that eligibility category has not had to ask anyone what their disability status is. So states don't know but when we've looked at surveys of those populations, you'll find somewhere, depending on the definition you use of disability, maybe a quarter to a third of the people have some kind of disability. And if you're looking at other things like chronic conditions, which many people consider to be that could qualify as a complex medical condition, it could be even more than half of that population, right? So I don't want to de-emphasize. Don't want to scare people, but I also want everyone to know that this is a huge extra burden on that population. It makes Medicaid more complicated and more expensive, and it will lead to a lot of people, 5.3 million people losing coverage. Many of them will be people who have these functional status or health conditions that affect their ability to do this. On the redeterminations, we've already talked about the Medicaid expansion change, which is the standard program now is you do a redetermination every year if your circumstances have not changed. It's going to go down to every 6 months. And then there's also changes in the law that halted regulations that were finalized last year that were meant to make eligibility easier. So those include for people who are eligible through disability pathways. These regulations would have made it so that states had to provide more assistance with determining what their assets were, like the cash value of life insurance and things like that, that often created barriers to people getting renewed because it's very hard to find that information and prove it. And there's also a set of regulations that changed how states enroll people who should be they're eligible for a Medicaid program that helps to pay for their Medicare cost sharing. And there's many people who should be enrolled in that program but don't enroll. And these changes in that rule would have made it so that people would be more likely to enroll. 800,000 people are going to no longer are not going to get that assistance with paying their out-of-pocket costs because of the changes, the freezing of those regulations that were already in place. The important point to note, if you're a policy analyst and all of the people, Rachel and I are both working on this, is that states can still implement these streamlining changes, but they don't. They are no longer being forced to by the federal government. So that is another change to the law. I don't have a whole lot of other things on the redetermination.
Yeah, I'll
And
just jump in. Oh,
just one clarifying question. If you qualify for an exemption, are you still subject to the semi-annual redetermination?
So that applies only to people in the adult Medicaid expansion. And I think that that's somewhat up in the air right now. I would like to do some further research on which groups would or would not be subject. I think there's some of that is dependent on guidance.
And I just wanted to make a brief apology. I realized that we all forgot to give visual descriptions of ourselves. I'm a white male, late 30s, with blonde hair and wearing a gray vest with a white collared shirt and a tie. The next time all of our panelists speak, if they could just give a brief visual description of themselves, that would be great. Rachel?
sure. Yeah, this is Rachel Patterson. I'll jump in on the next question and also say I'm a white woman with brown hair, wear glasses, and wearing a or a green sweater. Just plus one to everything Dave said, and I wanted to also make clear when we say redeterminations, we mean checking your eligibility for your ability to keep getting Medicaid. So if you've ever had to do that where you fill out paperwork and answer questions to say, can you keep getting Medicaid? That's what we're talking about. And what this would require states to do is make that process happen every 6 months. Again, these are paperwork burdens on people that are going to make it harder for them to maintain coverage. And a lot of the other stuff that Dave talked about is another reason that we opposed this bill so bad and continue to oppose it and try to reverse it. But like I said, we're trying to make sure that you have accurate information. Another thing you might see when he talked about the regulations that have been undone, one of the things that we tried to do in the Biden administration was say, if you're disabled, the Medicaid agency shouldn't require you to physically go to a place to renew your Medicaid. Unfortunately, this overturns that, so you might see states doing that again, requiring you to physically go to a certain place. I know states like Colorado are not going to try and do that, but of all the states in the nation, you might live in one that tries to re-exert that requirement. So these eligibility redeterminations every 6 months, they're different than the work hour redetermination or the work hour reporting requirements, but they are related because they're about maintaining your eligibility. And the Medicaid expansion is basically a description of broad Medicaid eligibility for low-income adults. So before 2010, before the Affordable Care Act, back in that time, Medicaid had these they called them the categorical exemptions. You had to fit into a category of a person. You had a disability, or you were pregnant, or you had young kids. What the expansion tried to do is to say adults generally who are low income get Medicaid. Of course, there's an income threshold. Kids were already covered, but this made it cover adults. The reason we talk about this expansion and what states have expanded and what haven't is because these requirements we're describing, the work reporting requirement and the redeterminations, they apply to those states, which is most states in the nation. I'm going to read the list again of the states that this doesn't apply to. With the asterisk of saying right? Doesn't apply right now. There's a lot of things that are still being determined, but I think it's important because some of these states have a huge population. So your work reporting requirements aren't going to apply in Alabama, Kansas, Mississippi, South Carolina, Tennessee, Texas, and Wyoming. Texas, huge population there, and probably also not in Florida, another place with a huge population.
Okay, thank you, Rachel. A follow-up to Rachel and Dave. How would this all impact HCBS? I believe all three of you mentioned the home and community-based services are optional services on the Medicaid program. And we've already seen reports of multiple states as they began the legislative session this year, or even late last year in the case of Colorado, to make budget cuts related to the bill. Can you briefly go into that?
I mean, I can start, Dave, if then, I mean, we are unfortunately seeing states put forward proposals that are pretty concerning um, about Medicaid. I believe the state of Idaho, the governor put forward, what if we eliminate home and community-based services? That's not for sure happening, but it is a proposal that the governor floated, which I think shows the level of concern and the level of cuts to state programs. They are being required to take a huge cut in the funding they get from the federal government, while at the same time standing up these work reporting requirements, these redeterminations, just a ton of extra work for the state. At the same time, they are getting less money. And so some of them are looking at cutting services, unfortunately.
Yeah.
Thank
Other
you,
states at
Dave.
cutting provider rates, how much they pay providers, which may make it more likely a provider will abandon Medicaid or stop taking Medicaid altogether, make it harder to find the services even if they're authorized for you.
Adela, would you like to add anything on this point?
Sure. In terms of state budget cuts, as I noted, we're definitely one of those states that is in that position. And I think somebody in the Q&A had noted that we're going to have to be spending, the paradox is that we're going to have to be spending a lot of money to put in systems changes and bring in new people to be able to build out this thing that these new requirements that are designed to keep people off. And at the same time, we are taking money away from the programs and benefits themselves. So we have put forward a number of reductions that relate to our HCBS waivers. We're not cutting full benefits, but we're trying to scale back or put some restrictions in place that allow us to have longevity and sustainability over time. David talked about provider rate cuts. That is also a place that we've gone across the board cuts as well as targeted cuts. So yeah, we're being impacted a great deal right now, and this is a multi-year issue for Colorado.
Thank you. This last question for Adela. How would these work requirement activity going to be reported, and what options exist if somebody did not have access to the internet or transportation to get to the job, or assistive technology if they're disabled and they need assistance, with to say, yes, I do work. Can you provide some background on that? I know all of this is still being determined, but
Yeah, so you're right. A lot of this is still under discussion, and we haven't even launched our stakeholder uh, processes yet. We're getting ready to next week. So this is a key point that we need to talk to our communities about. How can we help to facilitate you reporting that you've met some of these requirements. On the work requirements themselves, one thing that is at least a little bit helpful in the law is that we can look to see if people have income that is equal to or greater than the federal minimum wage, which is $580 per month. And then we'll be able to deem that they are compliant. So we won't even need to reach out to ask for anything from folks because we'll be able to see that in the system. We'll also be able to look at whether people have already complied with SNAP or TANF work requirements and use those for Medicaid as well. So again, we're going to rely to the extent possible on our databases and systems. And then if we have to, for example, if somebody is volunteering or for whatever reason their income isn't being reported in or maybe they're working the gig economy and we don't have a good way of tracking that, then we may need to ask people to provide some sort of documentation, and we'll use our app and our telephone and in person. But I think, as you know, there are definitely considerations and around accessibility that we need to be thinking about. And also, what kinds of documents are we going to need to help demonstrate compliance? So there's a lot still, like you said, to be figured out.
Right. And then this is generally for all of you. If you are eligible for an exemption if you're disabled, but you were told, no, you have to meet these requirements. What should you do? What's the quickest solution for that?
Well, I'm happy to take the first stab at this and let other folks jump in. Um, I think that right now, the best things you can do, and I'm seeing some of the questions and answers, people wondering, um, it's very complicated and confusing. Medicaid is not always called Medicaid. You might not even know, some people don't even know they're on Medicaid. The best thing you can do is to look in your state and know what eligibility group are you through? Are you eligible through? Are you in the Medicaid expansion? Are you eligible through a different pathway, like the SSI pathway, in which case you don't have to worry and things won't necessarily change very much for you. So knowing what that is will help you know. The second really important thing is to pay attention. If you will, everyone who is subject to these requirements by law and by constitutional right will receive notice that says you are now subject to these requirements. Okay, so you have to pay attention. If you get those notices, they may be very confusing. They may not make much sense. We've seen really bad examples of notices much more often than good ones. However, if it's confusing, don't ignore it. Ask for assistance. And knowing who to contact for that assistance, or for if you lose your coverage, who to contact for an appeal, the protection and advocacy organization in your state, legal services, your local Medicaid office, know who it is who you need to contact ahead of time so you can ask these questions down the road and people will be there to answer. And don't be afraid to push for your case and to ask questions, okay? Because this is a lot of times the systems fail people with disabilities. The systems aren't designed to be accessible for people with disabilities, and the more that you can be loud about it, the better chance that you get what you have a right to.
Yeah, I would add to that. David mentioned the protection and advocacy agencies, which you might know as disability rights name of your state, Disability Rights Washington, Oregon. Also, your local Center for Independent Living might have good information on this, especially if you get um, told that you have to meet this requirement or you do lose your coverage. Those are going to be local folks who are more likely to be able to help walk you through the process. I mean, some of the most important stuff you can do right now is like watching this webinar, getting informed, knowing that this is coming, telling people you know, telling your friends that this is coming. And then, yeah, like David said, paying attention to information coming from your state. And I don't know about you, I've definitely had official government correspondence go to my mom's house or a place I used to live. So that's another thing that is a possibility to think through. Could it have gone somewhere else? Can you update your address? That kind of thing.
All of
Thank
that
you.
is great advice, and I just want to second all of that. Make sure that your information is updated and pay attention to the notices in the mail. I know for Colorado's part, we ended up putting together an escalations process that was very specific during the PHE unwind. For people with disabilities who were getting swept up in that unwind process and should not have been, so that we were able to route and resolve those more quickly. So we'll probably do something similar this time around as well.
All right. Thank you, guys. Let me jump into some Q&A. One person said the presentation we've been going from the requirement for states, the requirement for individuals, to requirement for the federal government. Can one of you kind of go step by step and how that process works? You know, what did the individual have to do? What did the state have to do with the information that the individual gave them? And how did they document? How did the state document that information in order to comply with the federal requirements?
Do you care who answers?
I
No.
say go for it. You're from the state.
Yeah,
Yeah.
I'm from the state. And I think that that's a really good question. You're right. We were talking about lots of layers here. The state budgets are impacted. State rules have to change, and state Medicaid programs have to build new systems. But at the end of the day, the burden that, as Colorado, we're trying to prevent any kind of loss of coverage, but the burden for individuals is to potentially adhere to work requirements. And David was also talking about 6-month renewals. Now, there are a lot of people that will be exempt from those requirements. So it's important to pay attention to communications from your state Medicaid agency to figure, to identify whether you're in the category of folks who need to renew every 6 months or need to demonstrate that you have met the work requirements, or if you're not able to meet the work requirements, then to apply for some sort of exemption. So yes, there are levels of burden at every level, and hopefully I helped to clarify that a little bit, but I'll look to my other panelists to say more.
I might put it this way. Ultimately, what we are talking about is Medicaid beneficiaries who will have to report their work or education or training hours and continue to prove their eligibility much more frequently than in the past. Whenever we mentioned what the states have to do, what the federal government have to do, that was to try and explain things we don't know yet or where there might be complexity. But I would say ultimately for the folks watching this webinar, it's that those reporting requirements and those eligibility requirements that you're going to have to do and that are going to get harder. And so we're trying to make sure that folks have accurate information.
If you don't mind, I'm gonna move on to another question. There was two questions. One person wanted clarification on how they know whether they have Medicaid versus expansion Medicaid. And also how this will impact uh, NMADI versus MADI. I'm guessing that means modified adjusted gross income.
Yeah. Um, I'll set aside the finding out what your eligibility category is. I think that would be in your approval notice, and you may have to follow up with the Medicaid agency official. Um, that's a very good question, and I think I'll take that back. On the Magi versus non-Magi, um, this is a very complicated part of Medicaid. I don't want to go too much into detail, but Magi is tax-based eligibility. Non-Magi is sort of many of the disability-specific categories that people are enrolled through, parents and caretakers. Those are through this, or not parents and caretakers, but the disability-specific categories and some others are in a different eligibility system. The main changes that we talked about, redetermination frequency for people in Medicaid expansion and the work requirements for adults in Medicaid expansion are on the MAGI side. They're on the modified adjusted growth, the tax-based eligibility, but it's not everyone who's tax-based eligibility. It's just the people in those expansion categories. The non-MAGI eligibility, disability-specific pathways, like eligibility for 1915C waivers, is non-MAGI. Um, those those are affected by this law, but it's more that like the regulations would have made it more easier for non-magi to follow. It would have applied some of the magi rules that make it easier to stay enrolled in non-magi categories, and those are halted. So states no longer have to implement that. That's one of the main differences. But if you're in a non-magi category, you're not going to be subject to work requirements because that's a different eligibility pathway.
And that's the difference there between Medicaid versus expansion. Or no? Am I getting that right? Like a disability pathway with a non-Magi versus the expansion pathway which is based on Magi. That's the fundamental difference between whether you're eligible under expansion or not, or no.
Uh, if you're eligible through expansion, you are in on the Magi side. It doesn't
Okay.
really matter. But there are other eligibility groups like parents and caretakers or pregnant people who are Magi or children who are Magi categories but are not subject to those things. So it's just not that
Gotcha.
important for this bigger discussion. I don't want to confuse.
Okay.
It's just expansion eligibility is the key.
Thank you. Um, we had another question, if all of these people with disability provide proof of an exemption, and we've cut all the money from Medicaid and we reduced state's ability to fund the Medicaid program through provider taxes and stuff like that. How are the state gonna pay for all of these people to have exemptions?
That is a great question. That is something that we are working as Colorado, we're working very closely with our state legislators. Um, on figuring out what actions do we need to take now to help control cost growth over time. So there are, certain areas where we may be overspending in Medicaid that we need to curtail a little bit. But there's nothing that is going to make up for the massive loss of revenue that will come from the ratcheting down of the provider fees. And so that is a conversation for another day, but it has us very concerned because of, as I said earlier, 425,000 people are funded through those provider fees.
Thank you so much. It is 2 o'clock. We do have to wrap. We thank all of our panelists, Adela, Rachel, David. Thank you so very much for your time today. I am gonna put my email in the chat. If you have a question that we did not get to, please feel free to email me. My email is mlewis, Lewis, at aapd.com. If you send me an email with your question and specify whether it's a general question or question for a specific panelist, I can connect you with them. Again, like I said at the beginning, this webinar was recorded and it will be sent out with the transcript within a few days. Thank you all very much, and we will be sending a follow-up email with some links to important information, both from the National Health Law Program and from AAPD. We are getting ready to send out an explainer information about everything that we covered here, and we will be continuing to provide those resources as we get more clarity from the federal government. Thank you all and have a wonderful afternoon.